Thank you for sticking around. Thanks to those of us who are watching online as well. My name is Chris Galloway. I am from Friends of Medicare. I don't know if any of you have heard of Friends of Medicare before. Oh, yeah. Cool. I see board members in the room, so hopefully they have. If you haven't, we have a table out there. Come say hi. But really, I'm just here to help facilitate this last session for today. I'm so excited that we're doing it and that Andy's here as our speaker. He's a health policy researcher, political economist, and PhD candidate in the Department of Geography at Simon Fraser University. He's also a research associate with the Canadian Centre of Policy Alternatives. He also wrote a great report for Parkland Institute on surgical privatization that I reference all the time. Thank you for doing the work for me. I just point to it and say, read that. They know the answers, which is why he's here today. He's doing this session, which is titled, At What Cost? Surgical Privatization and the Threat to Public Health Care. And really, he's going to talk about what this privatization agenda means for patients, for Albertans, and for our public health care. So without further ado, I'll turn it over to Andy, and we'll get to questions after. Thanks, everyone.
Thanks, Chris, and thanks to Parkland for having me out here. Surgical outsourcing, as we know, is on the rise in Alberta and across Canada. Some governments, physicians, and investors rationalize outsourcing as a benign form of private sector involvement that maintains the integrity of public health care, free at the point of delivery, and is consistent with the Canada Health Act. But I want to challenge this narrative. In fact, there are costs to citizens, including the erosion of public health care, as governments pursue privatization and the intentional blurring of private and public health care. I'll review developments in British Columbia, Alberta, and Ontario. And I want to conclude on a hopeful note by discussing the evidence-based policy strategies that improve timely access to care, but require political will on the part of our governments and pressure from us and our movements. So in the next 40 minutes or so, I want to cover a number of different topics and really set the stage about how we got to this current conjuncture. I want to start by providing some context on the Cambie case in British Columbia, which was a direct legal assault on publicly financed healthcare in this country. And after the failure of the Cambie litigation in BC to unravel publicly financed healthcare, I want to discuss about how investors' strategies around privatization towards outsourcing of diagnostics and surgeries has really kind of been what we're seeing emerge across the country, and Alberta is really on the bleeding edge of that. I'll explain how there's a very intentional push by investors and some governments and some within the medical profession to blur the spaces of public and private healthcare. And that's really being done by rationalizing outsourcing as really a benign form of for-profit involvement in our public healthcare system. I'll challenge a lot of the myths around what outsourcing does and what it does not do. And I'll offer some evidence, as I said, about what can be done and the evidence-based strategies that we do have in front of us, but have not been widely adopted across this country. So first of all, we know there's lots of different forms of privatization. I'm speaking particularly about two forms that we see in healthcare. On the one side, we see private financing, also called two-tier healthcare, and this is private payment for hospital or physician services, either out of pocket or through private insurance. And private financing or two-tier healthcare has been really the long game by investors, insurance companies, right-wing think tanks like the Fraser Institute, and within some quarters of the medical profession itself. The second form of privatization, which I'm going to be more focused on, is outsourcing of publicly funded services, and this is often referred to as contracting out or for-profit delivery. And this is when publicly funded services are contracted to for-profit providers, including investor-owned facilities and corporations. So first, a bit of history about how we got to this current moment. BC has a long history of investor-driven healthcare, has long fought against the struggle against two-tier healthcare. Cambie Surgery Centre was established in Vancouver in 1996, and it's really central in this story. In 2007, BC's Medical Services Commission informed the CEO and orthopedic surgeon Brian Day that it would audit his two for-profit clinics, Cambie Surgery Centre and the Specialist Referral Clinic. And this was in response to patient complaints about improper billing and extra billing. But before it could conduct the audit, plaintiffs, led by Day, launched a charter challenge to try to strike down key sections of BC's Medicare Protection Act. And this is the law that protects BC's public healthcare system by banning extra billing and private duplicative insurance for services that are covered by the public plan or what we would say medically or publicly insured. Despite the plaintiff's efforts to block the audit, the Medical Services Commission audited Day's clinics in 2011. Even with limited cooperation at the clinics by Brian Day's staff, the audit found extensive unlawful billing by the two clinics. What we saw with the launch of this charter challenge was Cambie Surgeries Corporation, led by Brian Day, was the plaintiff in this litigation. The BC Attorney General, or the province of BC, was the defendant. And there were a number of interveners, including the coalition interveners, which were comprised of the BC Health Coalition, Canadian Doctors for Medicare, and a number of individual patients. And the Government of Canada later entered as an intervener once the federal Liberal government took office. The trial period ran from September 2016 to September 2020. So first of all, what is extra billing? At the center of the Cambie case, it was the ban on extra billing in the BC Medicare Protection Act. So just to give you a quick definition, this comes from the Canada Health Act. It's a bit of a wordy definition, but it's defined as billing for an insured health service rendered to an insured person by a medical practitioner or a dentist in an amount in addition to any amount paid or to be paid for that service by the healthcare insurance plan of a province. While somewhat varied, legislation in each province is designed to uphold the Canada Health Act and prohibit extra billing. And the Canada Health Act stipulates that provinces will have federal health transfers withheld for extra billing on a dollar-for-dollar basis. However, the commitment to enforcement of the ban on extra billing is quite varied across the country. And so this comes down to provincial ministries of health to enforce that ban on extra billing that exists more or less in all provinces. And in BC, we arguably have the strongest enforcement regime, and this is due to the significant and long-standing extra billing related to our for-profit surgical sector in the province and specifically to Cambie. So this as well may be a refresher for some of you, but I did want to, I think, give you a sense of really what was at stake in BC and its implications for other provinces. So Cambie Surgeries Corporation, again, led by CEO Brian Day, sought to strike down parts of the Medicare Protection Act as unconstitutional based on Section 7 of the Charter and Section 15. These are the three bullet points were the sections that Cambie Surgeries Corporation was intending to strike down. The ban on extra billing, the ban on private duplicative insurance, and the effective prohibition on dual practice. And what that means is creating limits on physicians taking payment from both public and private sources. So the aim of the Cambie litigation was to create healthcare markets and maximize profit-making opportunities by removing restrictions placed on doctors, investor-owned facilities, and insurance companies from billing private payers and the public purse. The legislation that was targeted, the BC Medicare Protection Act, is similar to legislative regimes used in other provinces to maintain a publicly financed system. The Cambie constitutional challenge was a direct assault on both public financing of healthcare and not-for-profit healthcare delivery. It's important to note, and this is something that I think there are many interests in this country who don't want us to know and certainly don't want the public to be aware of, but there's no outright ban on privately financed healthcare in Canada. There's no federal or provincial legislation that prevents doctors from working entirely in private facilities or patients paying out of pocket. However, legislation in most provinces is designed to force doctors to choose whether they're in the public system or not, and constrain their ability to have one foot in both the publicly financed and the privately financed sectors. And this is what's referred to as commingling. And this legislative framework exists for good reason, because it's intended to prevent the public purse from cross-subsidizing privately financed healthcare and investor-owned facilities, while also maintaining equity by preventing physicians from focusing their practice on patients who have the greatest ability to pay or access private insurance. In its defense, the BC government called upon many witnesses, physicians, senior health administrators, academics, and health policy experts, who provided expert testimony on the problems of both private financing as well as for-profit delivery. And after countless procedural delays, Justice John Steeves at the BC Supreme Court rendered his judgment in September 2020. In his 880-page decision, it's a great read if you have the interest and the time, Justice Steeve concluded that the sections of the BC law upholding publicly financed healthcare in BC are not at odds with the Charter of Rights and Freedoms. It's worth quoting here Justice Steeves. He writes, quote, "Duplicative private healthcare would increase demand for public care, reduce the capacity of the public system to offer medical care, increase the public system's costs, create perverse incentives for physicians, increase the risk of ethical lapses related to conflicts between the private and public practices of physicians, undermine political support for the public system, and exacerbate inequity in access to medically necessary care. Indeed, it would create a second tier of preferential health care where access is contingent on a person's ability to pay." And he added, "Wait times are caused by a variety of reasons, some of which relate to capacity in the public system, but others are associated with patient preferences as well as physicians' referral practices and how they manage their wait lists." The BC Supreme Court dismissed all the claims brought forward by the plaintiffs, led by Brian Day, and the plaintiffs went on to appeal to the BC Court of Appeal, which unanimously dismissed their appeal in July 2022. The appellants then applied to the Supreme Court of Canada for leave to appeal, and in April 2023, the Supreme Court of Canada declined to hear Cambie's appeal, ending the 14-year legal saga. And yes, I see someone clapping. That's well worth clapping for. Had Cambie prevailed, though, the Canada Health Act and its focus on equitable access would have been undermined. Doctors, for-profit facilities, and insurance companies would have had virtually unrestricted ability to charge patients and the public purse while also creating a private insurance market for all necessary health care. There is no question in my mind, living next to the largest health insurance market in the world, that we would see a movement towards US-style healthcare with large insurance companies determining healthcare access and much, much more for-profit delivery of healthcare. So while the principles of the Canada Health Act remain intact, many provinces and corporate interests have recalibrated their strategy to undermine public healthcare. In BC, Alberta, Saskatchewan, Ontario, and Quebec, corporate interests are becoming entrenched as more surgeries are outsourced, and we see the blurring of the spaces of public and private healthcare. Okay, so some of these characters may be recognizable to you. In the early 2010s, and certainly in the wake of the pandemic, with large backlogs for scheduled treatment, there has been a big push to increase outsourcing to for-profit facilities. And I think it's helpful to provide some policy history about how we got to this moment, especially in Alberta. The Saskatchewan Surgical Initiative, which ran from 2010 to 2014, has played an outsized role as inspiration as other provinces look to justify increasing for-profit activity. The Alberta government and right-wing think tanks like the Fraser Institute have constructed a seductive but erroneous narrative about the role of outsourcing in Saskatchewan's early success reducing wait times. When the Saskatchewan Initiative was introduced in 2010, the ministry not only took steps to increase surgical capacity in the public system, it also contracted with for-profit clinics to perform publicly funded procedures. However, the Alberta government attributes the short-term success of this initiative to for-profit involvement, surprise, surprise, and not the public system improvement and efficiency strategies, which included significant public operating room funding, first available surgeon referral models, and single entry referral pathways, as well as team-based clinics for a number of common conditions. So collectively, a lot of these types of initiatives are referred to as public improvement initiatives or public innovations. Wait time reductions during the Saskatchewan Initiative relied on a significant short-term injection of funding to expand public sector surgical capacity. Public hospital operating room funding steadily climbed from $129 per capita in in 2009 to $158 per capita by 2013. And this increased public sector capacity is also reflected in the increased staffed medical and surgical beds during the life of the Saskatchewan Initiative, which is another indicator that the increased capacity that sustained their wait time improvements during those years. And short-term wait time improvements in Saskatchewan really ultimately relied on this expansion of public sector capacity and efficiency improvements in public innovations. Despite this, the Saskatchewan experience has been held up by proponents of surgical privatization, including private sector consultants commissioned by the Alberta government, because for-profit surgical provision was the centerpiece of the Saskatchewan Initiative. In market-oriented policy experimentation, governments like to draw on policy models that support their pre-existing ideological beliefs. In this case, the Saskatchewan Initiative has been trumpeted as a success of privatization, a narrative that aligns with the Alberta government's ideological preference for greater for-profit involvement in healthcare. The reality of the Saskatchewan Initiative is documented in the 2023 Failing to Deliver report that Parkland published. But nonetheless, Alberta and Ontario governments in particular have made surgical and diagnostic outsourcing a centerpiece of their respective health policy agendas. And as we know, right-wing governments and corporate interests are not ones to let a good crisis go to waste. The surgical and diagnostic backlog created by the pandemic has been used to justify much greater for-profit activity. So by 2021-2022, nearly 20% of total publicly funded day surgeries in Alberta and Saskatchewan were outsourced to for-profit facilities. 17% in Quebec, 5% in BC, and about 3% in Ontario. Although, as many of you will know, Ontario is very much on the verge of moving much more in the direction that Alberta has been pursuing. While it may seem that opening more operating room facilities to offer surgeries increases capacity and reduces wait times, Canadian evidence generally shows the opposite to be true. The provinces with the greatest amount of surgical outsourcing, Alberta, Saskatchewan, and Quebec, which isn't shown here, have among the longest wait times for priority procedures tracked by the Canadian Institute for Health Information. Ontario and BC, which rely much less on surgical outsourcing, have notably shorter wait times for hip and knee replacement surgeries, which are shown on the slide. The Alberta experience is sobering. In 2019, the Alberta UCP government claimed that the expansion of outsourcing would reduce wait times. Drawing on data obtained from Freedom of Information, I found that in the first 3 years of the initiative, the province's total surgical activity actually declined. Fewer total surgeries were performed in fiscal year 2021-22 than in 2018-19. That is pre-pandemic and before the Alberta Surgical Initiative. Between 2018-19 and 21-22, total provincial surgical activity declined by 6%. And again, between those same years, surgeries delivered in for-profit settings increased by 48%, and surgical volumes in public hospitals declined by 12%. One of the critiques that was often made at the time of this release, and certainly by government, was that this is a reflection of the pandemic. But the reduction in Alberta Health Services AHS surgical volumes can't be explained by the pandemic alone. Since surgical activity in for-profit clinics increased between those years, so they were able to increase capacity and volumes in the private for-profit facilities, but they didn't do that in public hospitals. And this happened even as other provinces like British Columbia successfully increased hospital surgical volumes during that same period of time. The data also show government starved funding for public operating rooms. At the same time, government was signing multi-million-dollar contracts for new and expanded for-profit facilities. Alberta data reported by the Canadian Institute for Health Information found that the province, in fact, slightly shrunk its public operating room workforce between 2020-21, fiscal year 2020-21, sorry, these are long, and fiscal 21-22 by about 0.2%, so a slight reduction in its workforce, while BC during that same period of time nearly increased its public operating workforce by 8%. These are clearly political decisions, choices that are being made. In other words, the expansion of for-profit surgeries in Alberta has come at the direct expense of public hospitals and its workforce. And the most recent data suggests that the situation remains largely unchanged. Between 22-23 and 23-24, chartered surgical facilities increased their volumes by 32%, while public hospitals saw a 2% decline in surgical volumes. So again, we're seeing a continuation of this challenge where public hospitals are not able to increase their volumes, and yet much of the surgical activity is increasing in the for-profit sector. This is unsurprising when we look at provincial spending on public hospitals. In inflation-adjusted per capita terms, Alberta spent less on public operating rooms in fiscal 22-23 than pre-pandemic. In fact, Alberta spent more on public operating rooms in fiscal year 2009-2010 than in 2022-2023. The same is true for hospital medical imaging and total hospital spending. The story in Alberta is one of austerity for the public sector when there seems to be plenty of resources that are made available for chartered surgical facilities. And the poor wait time performance is not surprising. This is consistent with the international research literature. We know that public sector investment in surgical capacity is necessary to reduce wait time. So there's really no mystery here. Another important issue is that there's no public reporting of complications or serious incidents in for-profit facilities. And yet there's plenty of reason to be concerned. An estimated 82 for-profit hospitals in England were responsible for £250 million in extra costs to the public system over only 3 years, as patients were transferred to public hospitals due to complications in private hospitals. A growing body of research shows the risks of outsourcing health services to the for-profit sector. In a 2022 study by University of Oxford researchers published in the Lancet Public Health Journal, the researchers concluded that private sector outsourcing in England corresponded with significantly increased rates of treatable mortality, potentially as a result of a decline in the quality of healthcare services. This research team at Oxford continues to do some very interesting work and important work on this very topic. So as I mentioned, in the wake of Cambie, there is a very intentional push by investors, some governments, and some within the medical profession to blur the spaces of public and private healthcare, financing, and delivery by rationalizing outsourcing as a benign form of for-profit involvement. In BC, the Ministry of Health has stated, quote, "We have a publicly funded system that is delivered in large part by private providers, great family doctors, specialists, community health clinics, who are private businesses. And each year, the health authorities contract out to private clinics for acute care services. In doing this, the services continue to be provided to patients at no cost, with one payer, the government." In Alberta, former Health Minister Jason Copping said, quote, "It's the same service you get in the hospital, from the same surgeons, following the same clinical standards." In Ontario, Health Minister Sylvia Jones said, quote, "Our government is expanding community surgical and diagnostic centers so we can reduce wait times by doing more surgeries in state-of-the-art, convenient, and safe facilities, always paid for you by your OHIP card, never your credit card." And this is one of Doug Ford's favorite lines. Always your OHIP card, never your credit card. But the idea that this for-profit sector in Canada has not invited private pay, two-tier healthcare is a politically convenient argument, but it is false. Even by the conservative extra billing estimates from Health Canada and the provinces, we are seeing the greatest amounts of extra billing on record. This graph shows net deductions to the Canada Health Transfer from 1994-95 to 2017-18. The greatest deductions occurred in the most recent years on record. The latter half of the 2010s is when surgical outsourcing really began to take off in this country. So I would argue, not a coincidence. And when we take a deeper dive into reported extra billing by province, there's been over $200 million in reported extra billing in Canada between 2016-17 and 22-23. BC, Quebec, and Alberta accounted for the greatest share of extra billing, provinces with the largest and most entrenched for-profit surgical and medical imaging sectors. Again, I would argue, not a coincidence. Let's take a look at the experience in BC. The blurring of public and private healthcare has been underway for years in BC. It's a province with the most reported extra billing from 2016-17 to 2022-23, which totaled $115 million. And the slide should say 115 million where it says 99 million. This is largely the product of the BC Medical Services Commission conducting 12 private surgical clinic audits between 2017 and 2022. And this was based on agreement with Health Canada that those audits needed to be conducted. As a result, BC does have the most proactive audit regime in the country, but the province still remains non-compliant with the Canada Health Act because provincial legislation does not prohibit extra billing in diagnostic facilities for medically necessary imaging. And in British Columbia, the diagnostic imaging industry remains the largest recipient of outsourcing dollars and also the greatest source of extra billing. Much more of this is documented in a 2022 report I did for the BC Office of the Canadian Centre for Policy Alternatives, which is shown on the slide. So more specifically in BC, in that research, I discovered that False Creek Healthcare Centre, acquired by Kensington Capital in 2019, received $12 million in contracts between 2015 and 2020, despite an audit that had found evidence of extra billing. In 2018, the Public Health Authority canceled the contract when it discovered the extra billing. In 2019, the False Creek Healthcare Centre was acquired by ClearPoint, which is now the largest chain of surgical centers in the country. It's private equity owned. The new ClearPoint owner of False Creek Healthcare Centre in Vancouver lobbied the Deputy Minister in BC, and in an email I obtained under FOI said, quote, "Long-term volume guaranteed contracts will enable us to make an informed decision on the long-term sustainability of this business model." In 2020, so this is the following year after that meeting took place, multiple BC regional health authorities renewed contracts for 3-year terms with this surgical centre. In another example, the for-profit Kamloops Surgical Centre received $15 million in public payments between 2015 and 2020, despite an audit that found extra billing. Interior Health Authority continued to contract with the clinic during and after the period of extra billing, which is kind of shocking when there is evidence of extra billing that the Public Health Authority said, well, we're going to just keep contracting them. So let's turn to some examples in Alberta. Between 2015 and 2020, the now defunct Calgary-based Surgical Centres Incorporated received the largest amount of public funds for surgical outsourcing in BC. And in Alberta, AHS held a contract with Surgical Centres Incorporated valued at $155 million between 2012 and 2021. Upon government audit, Surgical Centres Incorporated engaged in unlawful extra billing in BC. During the same time, it held outsourcing contracts with AHS and BC health authorities. In BC, 3 Surgical Centres Incorporated facilities were audited by the provincial government with extra billing estimated at $2.1 million between 2015-16 and 2020-2021. In January 2023, the ClearPoint private equity-owned chain acquired Surgical Centres Incorporated, which at the time owned 1 surgical centre in BC and 2 centres in Alberta and Saskatchewan each. And as I mentioned, ClearPoint Health Network is now the largest chain of for-profit surgical and diagnostic facilities in the country. It's owned by Kensington Capital Partners, a Toronto-based private equity firm. They hold $1.7 million in their portfolio in IT, healthcare, and consumer services. And ClearPoint Health Network, operating as Canadian Surgery Solutions here in Alberta, is one of the largest contracted for-profit surgical providers in Alberta based on contract value. So these case studies of extra billing and 2-tier healthcare by facilities contracted to perform outsourced procedures are documented in the 2023 Parkland report if you're interested in having a look. All right, let's take a look at Ontario now. The Ontario government passed Bill 60 in February 2023 in order to provide an expanded legislative framework for healthcare outsourcing and for-profit provision. As I've shown, about 2% of total publicly funded surgeries are outsourced in that province. It's been a busy couple years. My report with the CCPA Ontario office documented that surgical and diagnostic outsourcing is about a $500 million industry in that province. ClearPoint has a facility called Don Mills Surgical Unit, and it received a 278% increase in funding from 2017 to 2021. The facility is receiving 2 to 4 times the funding that public hospitals receive to perform the very same procedures. And this is a story that Mike Crawley at CBC Queen's Park broke, and you can see the graphic sort of on the bottom of the screen. This is the CBC graphic just showing you the extent to the difference between what this for-profit facility is receiving and what public hospitals are being paid to perform the very same procedure. We also know from the intrepid reporting of Mike Crawley and other colleagues in Ontario that Don Mills charges $20,000 plus for orthopedic procedures for out-of-province patients. And I think there's a bit of this probably going on in Alberta. These providers, these corporations are claiming that the Canada Health Act allows for this if you're treating an out-of-province patient, and that it's a gray area. So they're working within the bounds of the law. Officially, we know that there's much less extra billing reported in Ontario, but we see no proactive audits like we've seen in BC. The Auditor General of Ontario has raised significant concerns about upselling and coercive practices, especially in ophthalmology for cataract surgeries. And the Ontario Health Coalition released a report earlier this year with case studies of patients who were unlawfully charged for medically necessary care. And if that wasn't enough, here's more. We're also seeing a growing socioeconomic divide in who is getting timely access to surgical care due to the growth of surgical outsourcing to investor-owned facilities. A new study by Dr. Robert Campbell at Queen's University and colleagues found that within for-profit surgical centers in Ontario, the rate of cataract surgeries for patients in the highest socioeconomic quintile rose 22%, whereas for patients in the lowest socioeconomic quintile, the rate fell by 8.5%. Dr. Campbell and colleagues conclude that, quote, despite new public funding for operations provided in for-profit surgical centers, which was intended to fully cover the overhead costs and remove the need to charge patients, this disparity did not increase, but instead grew during the period that these facilities received funding. In contrast, in public hospitals, the rate of surgery decreased similarly among patients of all socioeconomic status quintiles. Surgeons in private for-profit centers also have financial incentives to prioritize patients paying for extra services. Finally, surgeons working in the for-profit centers may have practices that focus on referrals for patients with a greater ability to pay for extra uninsured services. So contrary to what Premier Doug Ford and his health minister are so fond of saying, that you will never pay with your credit card, only with your OHIP card, we're seeing the opposite play out in that province. Outsourcing is paving the way to two-tier healthcare and intentionally blurring the spaces of private pay and public healthcare delivery. And the threat of US-style healthcare is very real in this country. In Alberta, you're certainly on the edge of this. We have documented interest from US investors in the growing Canadian healthcare market. Friends of Medicare, the Ontario Health Coalition, and the BC Health Coalition all received emails from a New York-based healthcare investment advisory firm as part of that firm gathering market intelligence. No doubt to be used in advising its clients, likely large institutional investors like private equity firms, about investing in for-profit facilities. This investment firm, the Marwood Group, in its email wrote, quote, hello, I'm reaching out from the Marwood Group, a healthcare research and advisory firm in the US. We're conducting research on the Canadian healthcare market, specifically looking at access to care, wait times, service availability, and level of public-private partnerships. We are reaching out to stakeholders, such as your organization, to get various perspectives and a better understanding of the overall market. Would someone at your organization have time for a brief discussion about the Canadian healthcare market? Thank you. And as I mentioned, much of this has been reproduced in my 2024 report, At What Cost, with the CCPA. To wrap up, after the failure of the Cambie litigation to begin unraveling publicly financed healthcare in this country, investors, including private equity, some governments, and some within the medical profession, appear to have recalibrated their strategy. The focus now is on using public funding to entrench for-profit facilities, a private sector workforce, and a corporate lobby that, once entrenched, will exploit governments and patients for both public contracts and private payment. And there is an intentional push to blur the spaces of public and private healthcare by rationalizing outsourcing as a benign form of private sector involvement that helps reduce wait times and does not undermine the integrity of Canadian Medicare. But when we look at the decade of experience in this country, we see that the outsourcing experiment is failing to reduce wait times and increase surgical capacity, as its proponents claim. I ask, at what cost do we allow the expansion of a for-profit sector when it comes with greater expense to the public purse and at the direct expense of the public sector workforce, constraining the capacity of our hospitals to increase surgical volumes and reduce wait times, especially for patients with more complex procedures that private facilities do not perform and do not want to perform because they're not profitable. Outsourcing serves as the first stop on the road to the main event, two-tier healthcare. How long can Canadian Medicare withstand the erosion of public trust if wait times do not improve? I think this remains an open question, but we must organize in our communities and through our health coalitions to demand governments act on evidence and pursue strategies that reduce wait times and serve the public interest. And so what are those strategies? They're abundant, there's no shortage of them, but they do require political will. First, the policy experience and literature overwhelmingly shows that outsourcing and private pay will not reduce wait times over the long term. Governments must tackle extra billing head-on by strengthening enforcement of provincial statutes and equipping our health coalitions with the resources needed to potentially pursue legal strategies should governments refuse to enforce their own laws. And we need to see the federal government withhold transfers for extra billing in a more meaningful way. We need a bold agenda of public sector improvement and capacity building that includes the implementation of what are called single entry models. So this means referring, rather than to an individual surgeon's wait list, referring to a group of surgeons so you see the surgeon who can see you most quickly with the appropriate expertise, as well as to a larger group of providers. So for example, in the area of orthopedics, having an advanced practice physiotherapist do the initial triage so that you're not waiting on a list with a number of patients who actually are not going to go on to have surgery. So these are the type of public system innovations that we need to see taken up across the country. They're not radical by any stretch of the imagination, but they're very practical and they make sense, and the fact that we have not implemented them now is an indictment of where we're at. We also need to see investments in our public operating rooms. This is one of the main determinants of whether jurisdictions are successful reducing wait times. We see this playing out across the country. We do not lack, in most cases, the physical spaces to perform more surgeries. By simply opening investor-owned facilities, that doesn't grow the workforce. And as the Alberta experience shows, we're simply shifting that workforce to the private for-profit sector. If we want to open shuttered operating rooms in our hospitals and extend hours into evenings and weekends, we must address the health workforce crisis in this province and in this country. And that means not trying to steal and outcompete other provinces and other countries for their healthcare workers, but it means building a healthcare system that respects healthcare workers and improves working conditions. We must also use science to reduce the preventable burden on healthcare by cleaning indoor air and mitigating transmission of COVID-19 and infectious diseases. These lead to preventable delays in surgical care and cancellations. I know that this province's government, unfortunately, has been one of the worst in terms of denying the reality of COVID-19 and the challenges that it brings our healthcare system. And finally, we must prioritize better primary health care and reducing poverty and health inequalities. Primary health care is the front door and must be the foundation of our provincial health systems. There's lots more to say, but I want to end there, and I thank you so much for your time and look forward to our conversation.
Thank you for that, Andy. That was great. There was a lot of information packed in there. We're going to go to questions.
During the course of your research, did you find that people understood that the governments were not being honest with them in terms of the fact that they were underfunding the public healthcare system in order to shift surgeries to private surgical facilities?
I would say, so it's mixed across the country. The experience is mixed in terms of the provinces that have continued to make investments. And I think there's a discussion about how much is needed and what that looks like. Certainly the story in Alberta is pretty clear cut in the sense that it is a story about austerity. Your government in this province has really been focusing those resources where there's a profit motive, right? And that's played out. To answer your question, across the country, there are some distinct differences about the relationship between public funding and wait times. A lot of the issues that we're seeing can't simply be solved by more funding alone, and hopefully that's a point that I conveyed. But I think certainly in the case of Alberta, it's that explicit policy choice of favoring and making plenty of resources available to chartered surgical facilities and starving public hospitals. And it plays out in different ways in different provinces based on the data. To your question, the Alberta story is a little more clear-cut than I think some other provinces for sure.
My name is Barbara. I'm a proud UNA member and a proud operating room nurse. This is close to my heart. First of all, to me, for-profit means the business is making a profit. With outsourcing, I am trying to understand where they are making their profit from. Is the government paying them what it costs to do the surgery in the public sector? Are they paying them more? And if so, are they telling us that's what they're doing? As an ORNS, the only place I can see profit coming from is by these centers cutting corners, using subpar equipment or consumables, using unqualified or less qualified staff that they pay less, and those people do not uphold standards of any kind. In your research, did you find out what the Alberta government is paying these CSFs? How much the public knows of what's actually going on?
Great question. So the short answer is no, I don't have the per procedure price that's negotiated, and that's why the Ontario experience and the story that CBC's Mike Crawley broke is so powerful, because it laid bare the fact that they were receiving a 2 to 4 times premium to perform the same procedure. I haven't tried to FOI them in all provinces, but in Alberta, it's very difficult to get the contracts that contain the negotiated amounts that the for-profit providers are receiving because of the way that freedom of information legislation works and the claim of commercial confidentiality. There's just a lack of data, and this is one of the challenges doing this kind of research, is so much of what is happening in the private surgical world is not publicly available. I can't go and download the data from the Canadian Institute for Health Information. It's not there, it's not being included, it's not reported. Provinces aren't reporting it. They're not compelled to release this information. So the work that I've done and the work that others have done has relied a lot on FOI, and there are certain limits to that in terms of our ability to get this information, which is in itself a huge concern about this policy direction when we don't even have the basic data.
I was very struck by that slide you shared of the emails from those American groups asking Friends of Medicare and so on, what's the healthcare market look like? Did you guys reply to the email? Do you just put it in the junk drawer, or do you just kind of mess with them? Because, yeah.
In BC, we took a meeting.
Yeah.
Yeah, we said, yeah, we'll talk.
I have a comment and then a question. Please don't use the word charter. I get furious every time I hear government talk about charter hospitals and charter schools, because it's an attempt to manipulate the public in terms of what they are. They're private for profit, and calling them charter sounds like there's something honorable about them. Chris, your comment about the certainty for business, isn't that why what was the one in Calgary that we bailed out? That's why they went under, because they didn't get the assured public dollars that they thought they would get. So in this incarnation of contracting out for-profit, it's very concerning that our government is saying, and we will give you commitments, assured commitments of public dollars for your profits. The last kind of thing I guess I want to say in a question is, what is going to happen with this refocusing and the 4 pillars? Because what you've just talked about, Andy, in terms of the lack of transparency and accountability is only going to get worse, multiple times worse, I suggest, here in Alberta. And I don't know if you've heard about, what is all happening with the refocusing, but taking control, particularly around surgical activity, away from Alberta Health Services is exactly what this government wants to do, to hand it over and control it going into private hands.
Great points just around chartered surgical facilities. I always talk about these are for-profit facilities, and I think people being very clear about what the motivation of these facilities is, I think is really important. I'll say I agree. Great points, I think, just around the lack of the secrecy. I mean, this is happening across the country. It's not perhaps the worst in Alberta. I think you got that. That's yours. You win that one. But it's a challenge everywhere across this country. Again, the Canadian Institute Health for Information, a national agency tasked with collecting health services data. The provinces aren't submitting surgical activity in private centers to CIHI. All of this work that I've done over the last decade, this has all come out largely through freedom of information. Even just getting surgical volumes happening in the private for-profit facilities requires freedom of information. So the integrity of our health system and knowing what's actually happening, we're quickly losing our ability to know what's going on.
Heather and I, we've talked about this, that there's the kind of reverse incentive now with guaranteed volumes that in a workforce shortage, we want surgeons to go to the private center because we're paying them for the surgery. So we're actually hurting our public hospitals further with our contracts.
I am a pediatric nurse and a proud member of UNA, and that was my president. Hi, Heather. She also stole my question. I just wanted to make a comment that I, like working at the Stollery, witnessing already multiple charge nurses with great experience in their 30s, early 40s, prime career, leaving, watching that brain drain, that skill drain, and going to the private facility is very disheartening. And something that's not talked about, like we're trying to strengthen healthcare and keep everyone together. It's very hard. And with those 4 pillars, like, have we seen other jurisdictions do this where they're unifying and then splitting and then privatizing?
Every high-performing health system is moving towards integration. Alberta is completely out doing its own thing, and this is not what high-performing systems have worked towards. So if you want to create chaos, this is a great way to create. And I think just some of the discussions we've had today, I mean, I think creating chaos is the agenda, right? That is the goal, right? So I think that has to be named.
1995 in Alberta, Ralph Klein decided to basically take away all the privatization, or so the public services of long-term care. Messed it up big time. We almost have an example sitting there of what's occurred in long-term care and what we've done. So if we took a look at long-term care, what it did to privatization, if we returned it back to a public system, we could literally free up 20% of the hospital beds tomorrow. So we have an example of what happened with privatization. Have we taken a look at evaluating the long-term care change that occurred in '95 to try to teach the public, here's where we're going to be in 2045 if we continue down this path?
Yeah, so reflecting on Nora's talk just around the importance of planning and how much we've lost, just talking to Chris too about the loss of expertise within AHS, the ability to plan health services effectively is going to be incredibly constrained. To your point about the loss of that capacity and what we're seeing playing out is alarming. Again, I don't think it can't be rebuilt, but we're seeing the same public administration challenge across the country too. It's not just in Alberta, it's in BC, it's in Ontario. What we also need to attend to as progressives is the importance of strong public administration and good public agencies where we're recruiting and drawing people in who are motivated. And I think one of the big things that we see in a lot of these public sector ministries of health is they're struggling and they're not retaining the people that we want to be there. This is a larger, probably a separate conversation, but I think a really important one just around planning on the long-term care front, seniors care. We know also those access challenges have the effect of also creating longer wait times for everyone. If people can't flow through hospitals in the way that they need to, and you don't have the inpatient beds for folks who need an inpatient stay after a surgery, you can't effectively flow people through, and your wait times are going to be challenged on the surgical side. So I think it has to be approached as a system, and that planning, and especially what's happening in Alberta, is alarming in terms of the loss of that focus and the siloing now of different areas of the health system.
I just had a question about whether or not you or other people in this room are looking at kind of the privatization that's occurring in the recovery or addiction space. It's recovery capitalism is what I would call it. And in Alberta, you have these massive contracts that are given to ROSC Solutions based in BC. They're affiliated with some professors at SFU, addiction professors, people with, not really clear addiction treatment records, I would say, and then also a new one that emerged in Calgary, Bowline Health, and they are being wedged into the addiction treatment space in Alberta. They train their own staff. They call it recovery coaching. It's a 5-day training that you can take. The only qualification that you need to have really is lived experience. And not to say that lived experience doesn't count, but addiction care is healthcare. The addiction crisis that we have right now in every province across Canada allows for this free pass of funds to go to these private agencies that don't have track records. They have businessmen on their boards. They don't have representatives from the healthcare sector. So I'm just wondering, will you be looking at that in your work? I hope that you can connect with other people who can do what you've done to kind of break down what's happening in surgical wait times with what's happening in other aspects of healthcare.
We've had some BC exports come to Alberta. I'm very sorry for that. It's unfortunate how much it is gaining traction, and certainly I think there's been a very concerted effort in Alberta to give these folks prominence and platform them in a way that is not rooted in science. It's not rooted in basic human rights. A lot of the practices happening and ways that these operators provide their service is very concerning. I'm not doing any specific work on it at the moment. I know there are folks in this area that are doing work. I mean, it's a great point. I think it does deserve attention. Even in BC, we're seeing kind of the recovery industry gaining more traction than it's had. It's definitely a concern, and I think the conditions that folks who are trying to access services find themselves in is quite troubling, because, as I said, a lot of them they don't take a human rights approach. They're not evidence-based. It's a really sort of anti-science movement, and it's a really quite a concern.
My name's James. I really can't be quiet about this. I am a United Nurses of Alberta member. I'm a surgical nurse. I work in the operating room at the Calgary Foothills Medical Center. Problem that we're seeing mostly is with the private sectors is not just so much that we're finding that we're having a difficulty finding surgeons. The problem is affecting surgeries is that we do not have enough anesthesiologists. There are doctors retiring left and right. They're tired. They don't want to work anymore. We're getting a lot of new anesthesiologists, but they don't want to work at facilities like Foothills. They're starting to shift their practice to all different facilities. They're going out of town. They don't want to stay in one facility like a lot of the seniors anesthesiologists did.
I think one of the things that we don't talk about a lot, we should, which is that among many specialties, specialist compensation has really exploded in this country. We don't have the time commitment in terms of the workforce commitment from among some of those specialties where they are very well compensated. And this is in large part a product of fee-for-service compensation. Dr. David Urbach, who's the head of surgery at Women's College Hospital in Toronto, the fact that predominantly surgeons are running their own private businesses. I mean, most of them are paid for entirely by the public purse, although we're seeing, as we've talked about, with lots of examples, that private payment extra billing piece is a growing problem, especially with more for-profit activity. This is the challenge of how do we work towards building a more integrated, a more public system when we continue to have a fee-for-service independent contractor model where it allows sort of the ability to choose when you work, where you work, how you work. One of the strategies we have to be taking seriously is there are some shifts in workforce attitudes of how people want to work and how they want to practice, whether it's nursing or medicine. I think the public system has to do a better job of reflecting some of those changes. To this point, we haven't done enough on that front. In the UK, it's often called a portfolio career. Like, how do you work within the public system but have more opportunities to do different things at different points in your career? And so I think there's a lot of ways where the for-profit or the privateers are taking advantage of some of these changes in workforce expectations. Some of them, I would argue, are a function of greed. You know, people want to have more work-life balance. Who can blame them for that, especially when working conditions are challenging? So I think we have a lot of work to do within the public sector too, of how do we make it work for people with families, but also how do we retain and keep folks who are nearing the end of their careers within the public systems. I think there's a lot of work where we can improve that and increase recruitment and retention.
I'm Danielle Larrabee. I'm First Vice President of UNA. So the focus on this has really been on outsourcing and what I would say privatization by stealth, right? This idea of privatization under the radar. We like to think we have an efficient system. Well, we really don't if we're paying double for everything, basically being privatized otherwise. The Conservative Party of Canada health critic, who is a doctor himself, has made it very clear he wants to be the last health minister Canada ever has. To me, that sounds an awful lot like the Canada Health Act wants to go bye-bye. So have you given any thought in terms of what it would mean to have that happen and to move towards an opportunity for fully open two-tiered healthcare and what we could be doing in advance of that and should be doing to make sure that that doesn't happen?
I think it's something that we are getting glimmers of. We're seeing what that future might look like across the country as this for-profit sector becomes entrenched. I don't think it's a given, though. I think, I continue to, for what it's worth, public opinion polling still shows strong support for public health care. I think the issue that they're exploiting is this idea that it doesn't matter who provides it, right? If it's a for-profit center, that's just the same. It's the same surgeon, it's the same public health care. And that's the narrative that we're hearing from many of the provincial governments. So I think the political fight of tearing down the Canada Health Act, while not impossible, I don't think even a far-right federal government would necessarily take that on immediately. I do think what they're doing is what they're doing in Alberta, which is how do we create the conditions where this for-profit lobby is very well entrenched, and then you can start exploiting private payment, even though you're saying we just do publicly funded procedures. And that's really what I'm trying to convey is that's not the experience, like that's not what we've seen. So the Canada Health Act is a beautiful piece of legislation. We need to fight for it. We need to fight to maintain it, but we also need to recognize that publicly funded for-profit delivery is coming at us in many different shapes and forms, and we have to take that on directly. And we have to take it on, and I think we need to start talking about what are the legal strategies to force governments to enforce their own legislation. Because many of them are not enforcing. We know quite clearly, I did a global interview. People are paying out of pocket for medically necessary imaging all over this country. The stories in Alberta are widespread. They are blatantly advertising private pay MRIs. That is extra billing, but governments are not being compelled to enforce their own legislation. So I think we have to think about some of those strategies, and our movements have to confront them. So I hold out hope, and I think we have our work cut out for us.
Awesome, thank you. Let's give Annie a big round of applause.